is not possible, which happens most of the times, then it can be stored at 4 degrees centigrade, but for not for more than 12 hours. Because then lot of contaminants do start growing in.
Fine. So over to Dr. Anjali. Now, how do you diagnose UTI? Now the routine has been there, you have your culture reports, now how do you interpret the reports?
So for diagnosis of UTI, the guidelines now suggest the simple bedside test, which is a urine dipstick test. And it has a good sensitivity and specificity, which should include both leukocyte esterase and a nitrite test, and it's a simple bedside test. If feasible, we should also send a urine microscopy, but it should be Dr. Neha has also told, it should be sent to the lab as soon as possible in a freshly voided sample. Coming to the urinary culture reports, the culture should be interpreted in the presence of, when we know what is the specimen of the child. For example, if we take a midstream clean cat sample, the colony forming units ranges from 10 to the power 4 to 10 to the power 5 colony forming units per ml of urine. While in a urethral catheterized sample, it should be more than 10 to the power 4 colony forming units per ml, while in a suprapubic sample, it should be more than 3 colony forming units per ml of urine.
Fine, so few points for the pediatricians. As what has changed from the last guideline, which was published in 2011, so almost 12 years back, the midstream clean cat sample used to be 10 power 5. Now it is more than 10 power 4 to 10 power 5. The sensitive, like you can say, the colony count has slightly been reduced because there were chances that you may miss around about 5 to 10% of UTIs in those children, especially when they are voiding more often or when it's a newborn, when you do not get enough time for the urine to stay inside the bladder. Suprapubic initially used to be any number of pathogens. If it is there, it is taken as positive. Now it's 10 power 3 because majority of the times, a lot of labs are not going to report as 10 or 100. They'll just say less than 10 power 3, more than 10 power 4, more than 10 power 3. So hence this has been replaced and it's also increased the sensitivity. Now coming to this diagnosis of UTI.
I just wanted to add a point, there were few studies in which they collected a suprapubic sample and as well as the sample from the midstream cat sample, and it was shown that if the suprapubic sample, if the colony forming unit was significant, which was more than 10 to the power 3, in all those cases, the colony forming counts in the midstream sample was not always more than 10 to the power 5. So there was chance of missing those children with suspected UTI if we take the cutoff of 10 to the power 5. That's why the cutoff has been decreased to 10 to the power 4 now.
4, 5. Above 4 is above 4.
This is right, actually. So 10 to the power 4 should be the cutoff, and the guideline says like this, 10 to the power 4 to 10 to the power 5, but 10 to the power 4, if we have in a presence of symptoms, we'll consider this as a positive urine culture.
So,
ma'am, this is the same. This is the current recommendations. No, ma'am, it is not different. It is now, actually, previously we used to take the cutoff of more than 10 to the power 5. But now the cutoff has been decreased to 10 to the power 4 for the same reason which I have told you, because if we take a more higher cutoff, we are going to miss few kids. That's
if
why
you
the
go
cutoff
back to
is
the, if you, so 10 power 4 wala 4 to 5 इसलिए लिखा गया है so that the change is there. Because if you go back to the historical controls, how did this 10 power 5 came in? It was in 1960s, you can say study was done in pregnant females to pick up how much cultures, how much should be the colony count and what should be the significant stuff for that. So from that it has been extrapolated. But from the recent literatures that have been coming for pediatric population, it says even 10 power 4 is significant in the presence of a clinical symptom. Hence it has slowly been coming down. Now coming to this diagnosis of UTI, just wanted to add, now the dipsticks, initially dipsticks was an optional kind of thing. Now it has been made mandatory that you keep it in your private clinic. The moment the child comes with a suspected UTI, you just do a dipstick. So leukocyte esterase is a surrogate marker for WBC in the urine, and nitrite actually tells you about rapidly, you can say the bugs which are producing nitrate reductase. and converting nitrate to nitrite. So it increases the chances of picking up an active UTI in the child. So if the nitrite is positive, leukocyte esterase is positive, and within say around 2 to 5 hours, the patient comes with with a urine routine report also, which shows pyuria is there. So in those scenarios, your pickup rate for a your UTI is almost to the tune of 99 to 100%, which is like a gold standard of a urine culture positivity. So this has actually come in vogue to pick up UTI early so that you can start your initial therapy early without waiting for the culture report. And regarding this pyuria, if you say there are two values that are there, more than 10 WBCs per millimeter cube in an uncentrifuge sample and more than 5 WBC per hyperfield in centrifuge sample. Most of the labs will not report centrifuge, non-centrifuge. So how do you judge? So what you have to see is the units. If it is per high power field, it is centrifuge sample. And if it is per millimeter cube, it is a non-centrifuge sample. So this is how you judge which values to be taken.
But this centrifuge sample, they should have higher values of WBC. Why this is lower?
It is checked in this thing,
The-
Newbar's chamber.
No, when you centrifuge,
No, sir,
the
sir,
concentration has to be
Dr.
more.
Sharma, this is the high power field is the one which we see in the microscope, and this is in the Newbar's chamber
Newbar's
where we
chamber,
are
it is
counting
counted.
WBCs in unfront centrifuge sample. That's in the Newbar chamber, which nobody does. All the reports you will get in the lab is on the centrifuge sample, and you have to see the number of WBCs with the high power field. I think that is theoretical one which we would do it in a side lab in a Newbar chamber, but nobody in the
So
lab practically does.
So I'll just put it forward, like in Gangaram hospital, we get a urine routine report. So there it is per hyper field. But when the culture report comes from the microbiology department, it also says the amount of WBC is there. So they report it as per millimeter cube. So different labs will have different this values. So does all pyuria reports suggest UTI? So Dr. Atnu, what's your take on that?
Yeah, no, it has to be a positive culture along with the leukocyturia, because isolated leukocyturia doesn't give a final diagnosis of UTI. It can be there in fever, in any inflammatory conditions, even Kawasaki, glomerulonephritis, renal calcular disease, and whenever there is a catheterization or history of catheterization. So they also can present, there also the reports can be shown as leukocyturia. So we have to have a symptomatic child, you have to have a urine culture positive, and then of course leukocyturia is significantly.
So avoid just seeing the WBC reports and labeling the child as having UTI, because there may be 10 to 15% of the kids who may not have a UTI. Like example, a child with stone disease. So he may come with dysuria, increased frequency of urination, WBC in the urine, but this child may not be having UTI. So think twice before labeling as UTI. Now, what treatment will you offer to a child with suspected UTI while still awaiting a urine culture report? So, Dr. Vasudev, what's your take?
Yeah, I think again, this is a very common scenario that the child has come with symptoms of UTI, that means dysuria or a fever, and again, it will depend upon the age of the child, severity of the symptoms, and also any other risk factors. So, we have to keep in consideration all these things. And if the child has got fever which is more than 48 hours, and we do not have evidence of viral or other things, and the child is lesser than 2 years of age, I think these are cutoffs. And if the child has got any high risk factors, we'll talk about what are the high risk factors. If the child is less than 2 years and he has got a LE or nitrite positive along with the symptoms, we would suspect UTI, start this child empirically on antibiotics before and send the culture. Before starting antibiotics, send the culture. Now, once the culture has come and it is positive, we would continue with antibiotics. But if the culture is not positive, we would look for other causes of fever rather than UTI. And on the other hand, if you have got a child who is very young child, less than 6 months, and even if the LE is negative and nitrites are negative, we would keep this child under observation and send a culture. And if the culture is positive, we would start treatment. But on the other hand, in a younger child who's got risk factors like VUR, recurrent UTI, bowel bladder dysfunction, these are the children, younger children who may land up with problems. So we have to be little cautious. If LE or nitrite is positive, again, we would start on antibiotics, look for culture. Culture is positive, we would again continue the treatment. And apart from that, I think why are we so worried about treating younger children or symptomatic UTI with LE positive, leukoestrase or nitrite positive? Again, children who have got recurrent UTI are at a higher risk of scarring in the kidneys. And if the child has got recurrent UTI, if you see, if you are delaying the treatment even by a day, it can cause damage. So children who are treated early at 48 hours vis-a-vis who are treated after 72 hours with fever, you see the scarring rate goes so high. It is almost double at if you are treating the child with fever after 72 hours who has already got UTI vis-a-vis if we treat early. So the carry home message I think is that if the child is suspected to have UTI with symptomatology, LE is positive or nitrite is positive or WBCs are more than 5 in a high power field, that means we are dealing more or less with UTI and we start the treatment early, send the culture. If the culture is negative, we can always stop the treatment. But again, delaying the treatment may be more detrimental and can cause further scarring and damage.
So take home message is start your treatment early. That's why those dipstick methods have come in, so that you prevent damage to the kidney. Because
Dr.
every
Vasudev,
24 hours is increasing the damage.
For this dipstick test, do you need Medistim urine or any urine will do?
See, in fact, for that we